Yeah, I request the next speaker, Dr. Sonal Jadhav, to talk on complex retinal detachments.
Thank you so much, the chair and the All India team, for giving me an opportunity to put up a topic which I think has always been a challenge for most retina surgeons. They don't have a pointer, I'm so sorry, but I think we'll try and uh, manage. I'm going to put you through a series of few cases like giant retinal tear, high myopia with detachments, iris prolapse with GRT, RD with iris claws, and a separate case which is a Coats disease case. Let's start with my first case. This was a 45-year-old male who had. Has it started? Yeah, this is a 45-year-old male who had come to us with a giant retinal tear with a detached choroidal detachment. You can see the choroidal fluid coming out of the cannula. But every time that I would put the cannula, I would probably not be able to see the cannula because it was going in the subretinal space. Tried and changed the position of the cannula. At that time, was confident probably that the cutter was going there. Put the infusion line again, started my vitrectomy, and just in a little while realized that I was seeing a big mound that was coming back, and the cannula was back in the subretinal space. So sometimes in these patients, you see completely at the clock hours of the GRT, you will see a complete pars plana which is totally off. So in these cases, you are only then getting used to putting large, longer cannulas, the 20 gauge cannulas that are there inside. Once that's done, then we go ahead with your regular vitrectomy, put in PFCL, flatten the entire GRT edge, do a good vitreous base excision at that point. PFCL becomes our third hand over here. In some cases, if the edge of the GRT is rolled up, you can use soft tip to flatten that edge very, very well. And once that's done and you're confident that the edge is completely flat, you go in and you do a good laser and exchange it with PFCL, or you can do a direct exchange or do a fluid exchange and then put in silicone oil. These cases have always been a challenge to manage. Most of our GRTs now do very well. Today, with the advanced new cutters, we are very confident to do a good vitrectomy and a good vitreous space dissection. This was my second case. This was a high myopia patient with a bullous RD with extensive PVR and multi-layered vitreoschisis and with a posterior staphyloma. This is the norm that we see in most high myopic patients. A very careful vitrectomy has to be done in this patient. The vitreous membranes have to be very slowly peeled off because inducing PVD is very difficult, and you can definitely occur a lot of iatrogenic breaks. In such patients, PFCL, which is mainly a third hand and also helping us to assess the traction, further traction, is very difficult to put in such cases because of posterior breaks and sometimes invisible breaks which are there in the staphyloma area. So very slowly here, circumferentially in the direction away from the disc, we are kind of peeling the membrane with the help of a forceps and the help of our cutters. As I said, the new cutters which have the port which is very close to the shaft tip help us with doing good vitrectomy. In such cases, in bullous RDs, it's very difficult to do a vitreous based dissection. So I'm going to take a small show a small trick that is used later in this surgery. Slow and steady vitrectomy is done in these patients. You can already see a small break which is there at the inferior arcade, which is posterior. The entire membranes are very slowly peeled off with the help of your forceps today and with your cutters, as much as you can manage peeling these membranes till you are confident enough that you can now do a fluid exchange and flatten that retina. So once the membranes are completely off and you know that you can see your posterior break, you can also do a draining retinotomy in such patients. And then once you are confident that these membranes are totally off and you have cleared most of your vitreous at the posterior area with the help of your cutter and your forceps, the next step is to go in and nicely do a draining retinotomy, do a fluid exchange, and flatten the retina. This is the next step that is going to be shown in the video. The light, the endolight also, the shaft of the endolight can also help us sometimes when we are doing these vitrectomies, because they can support the retina as a third hand. So that also helps us in. So you see these membranes, it was multi-layered, the entire vitreous, and as a result, it was extremely difficult to peel these membranes. As much as possible was done. Finally, a fluid exchange was done with the help of a retinotomy and the posterior break, and the retina flattens. We also do a small draining retinotomy in the staphylomatous area to remove the fluid that is below the staphylomatous area. Once this is done, I think now in an air-filled eye, as you're more confident and you can have very good visualization, it's the time when you touch the further vitreous-based dissection, because the retina now doesn't jump up in your port. You maintain a good air pressure at 40 to 50 millimeter mercury. You complete the entire vitreous-based dissection, and in an air-filled eye, it becomes very easy because you can see almost right up to the aura. You don't need to indent in such cases, and you can do a good vitreous-based dissection, and then you're very confident that your surgery, in any complex RD, a good vitrectomy is the answer to doing a successful surgery. So once this is done, and then we can go to endolaser, laser all the breaks, and put in our oil. Eventually, this patient did very well. I'm just going to finish this video. This is the laser. You can almost see the aura right here. You don't need to indent at all in an air-filled eye. You finish the laser and put in oil. And I go back to my third case. Now, this was an interesting case that was sent to us with traumatic spontaneous expulsion of the IOL with iris prolapse, with a detachment and choroidals behind. And in this case, a phakic.
Our time is up. We can have a brief discussion on this case.
Okay, so
I just see that in this previous case, the drainage retinotomy is probably not necessary when there was solely peripheral breaks, and the drainage retinotomy was done in the staphylomatous area where there's no RP and all.
That's
it would
true,
be
sir, but
difficult
then there was a big posterior
around.
bowl of fluid. So sometimes right close to the arcade, I prefer to do a small, if in case I cannot take that fluid out, because I was not having the advantage of using PFCL here, because there were small breaks at the posterior margin. So I probably did a small draining retinotomy in that case. So I think I'm just going to go ahead, and probably, I know I have long videos here, but this was an exudative case, sir. But just a take-home message in complex detachments, a 240 band encerclage in severe PVR cases or inferior RDs or recurrent RDs, tricot definitely helps us to assess PVD. New age cutters are very useful. PFCL as a third hand and to assess the remaining traction. Chandeliers were bimanual surgery. A light pipe as your third hand. A brilliant blue dye below the PFCL to stain the membranes and peel them better. Anterior flaps of large breaks better cut away. In large retinectomies, focal attachment points should be kept in non-traction areas, and a draining posterior retinotomy in cases of staphyloma. I'm sorry with that. Thank you so much.
Thank you, Dr. Sonal.